Good morning, good evening, and hola to uh, good evening and hola to every UB expert from Mexico and also from every corner from the world. So I am Dr. Aaron Tan Yuchin from Malaysia. It is an honor to be invited by ISUBE to share this talk. And today I'm going to share it with everyone regards to my single center experience in UB surgery and what my personal technique tricks to reduce the challenges related to its steep learning curve. So I work in a Summit Medical Center, Penang. It is a 180 beds hospital in Penang, which is the northern aspect of Malaysia. It is south to Thailand and also north to Singapore. So I'm a private doctors, and in private practice, we encounter many spinal stenosis or also PID, which is manifested in the form of neurogenic claudication or sciatica. We are living a pretty conservative with high resistance against high open surgery. So naturally, full endoscopic surgery has become trendy in our country. The study shows that endoscopic surgery is equally efficient as compared to open surgery or microsurgery, with small incisions, effective, minimal pain after the surgery. However, endoscopic surgery is not without its own unique challenges. It has a steep learning curve, very narrow surgical view, limited instrument movement, long operation time, less efficient with potential complications related to inadequate decompression. And this is especially true for one beginner surgeon who just kicked off their journey of endoscopic surgery. The reason why I choose UBE is that not only maintain the minimal invasiveness of endoscopic surgery, it provides clear, wide surgical view, working flexibility with wide surgical indication. So in short, I think that it is a minimal invasive endoscopic surgery, which is as powerful as open surgery. I started UB surgery since the beginning of 2023, and I've performed my own pilot study who recruited 30 patients with sciatica and neurogenic claudication because of a severe prolapse interval disc or spinal stenosis. I included those patients who have heavy symptoms that fail conservative management for 6 weeks, and they need to have an MRI finding of herniated disc with a compression of nerve root, Durasec, or high-grade lumbar spinal canal stenosis. So excluded those patients with high-grade spondylolisthesis, coexisting hip or knee joint, or also those without clinical radiological correlation. So I use two parameters as my post-operative assessment. Number one, pain score, working capacity, which I measure before surgery 1 month and 3 months. The magnet criteria was measured 3 months after the surgery, and the periodic outcome will compare. Use a PATI test at a 0.05 significance level, and I use R version 4.2.2. So as for a VSS score, we can see a significant reduction of pain score before the surgery, 1 month and 3 months after the surgery, with a p-value of less than 0.0001. And as for the MAX criteria, all of the patients regards the procedures as good or excellent. And for the walking capacity, we can see a significant improvement after the surgery. So the graph itself is a self-explanatory, and I think that the UB definitely give a good result. So I'd like to declare that throughout my 1 year of embarking UB journey, There's one patient who had a dura tear, but he has no symptoms, and that's occurred on the patient who might perform a cervical foraminectomy. It's not included in this study. And one patient was suspected to have insufficient decompression who recovered after 1 month of conservative management. There's one conversion to microsurgery. Again, this patient is not included. None require reoperation. Generally, UP is associated with 6 to 10% of complications. And for private practice, I think it's a high figure. So I myself adopt certain tricks that I learned from a few experts. And the aim is to minimize the complications that's associated with endoscopic surgery. So I would like to share with everyone, number one, positions of the patient. So like in unipolar surgery, sometimes we tilt the image intensifier, but I think that's more convenience for us to tilt the operative table. I would like to position the head up and down, and the main aim is to position the D line perpendicularly to the floor. It's important for us to strap the patients to avoid the patient slide because we marked the important endoscopic anatomical landmark prior to the start of the surgery. Slight movement will confuse us. For the beginner, I think it's important for us to use this tool if the operative table is too high, as we know that sometimes when we want to allow the image intensifier to come in, especially for lateral view, we might have to elevate the table. If the table is too high, then it could be very tiring for beginners. It's important to make sure that simple things like the pedals of the plasma RF device and high-speed drills are comfortably placed. We do not want to struggle to look for those patterns while we are focusing on our endoscopic surgery. Then definitely the scope orientations and optimize the focus before starting surgery. As for the skin incisions, I prefer to start my incision slightly lateral. Uh, that is to allow me to work with a wider room. And this is especially true for those patients with a thick spinous process. I want to make sure that my scopes and my instruments are at least 2.5 to 3 centimeter apart to avoid conflict between the instrument and the scope. And this is inspired from the Chinese UB surgeon. I would like to place my working portal nearer to my target. So previously was mentioned by Dr. Yang Hejin from Zhengzhou, China. He likes to place the working portal 1 centimeter from the D line and also the scope portal 2 centimeter from the D line. So I always use the dilator to dissect the soft tissue of the bone bluntly. So that will save a lot of time as it allows us to visualize the Son's triangle or also the initial working space more easily. So prior to the surgery, I always gauge where I would reach the fascia. So I would measure them using MRI, and the skin incisions need to be deepened to the depth of the fascias. I think that for beginner, a slightly generous fascia opening is very important as it allowed us to pass in and out the instrument smoothly. So water flow is again very important. Even after the insertions of the instrument, the water outflow should be smooth even after we insert the instrument to prevent the water collection in the operative field. So as for the triangulations, I think we need to perform it straight down to the bone, right? Sleeping techniques are important. It's basically a technique to rub the powder sheet and the instrument together to eliminate the soft tissue between the instrument and also the scope. A 30-degree scope will allow wider visualizations as compared to a 0-degree scope. And this is the Son's triangle for a left side approach. And this is a right side approach. This is the multifidus muscle, and this is the interlaminar space. So it's important for me to expose a certain important anatomy before I start the surgery. So this is the interlaminar window. I usually measure it before my surgery, and I use my RF device, which is around 5 mm in diameter. This part is 4 mm, then the bare part is extra 1 mm, so it's around 5 mm. So I use that to as a tools to perform my measurement intraoperatively. I regularly expose the base of spinous process, the cranial lamina, the caudal lamina, then the IAP. But however, sometimes the medial edge of the IAP sometimes is obscured by the capsule and also the superficial yellow ligament. And this is the right side approach. This is the caudal lamina. Then I'll follow it. And this is the SAP should be around here. It's not obvious during the surgery. This is the base of spinous process. I've performed slight drilling, and this is the IAP. So I like to do a few of pre-operative measurement and correlate them with the UB endoscopic surgical landmark. So this include the fascia, the surgical field, because I would like to know how much I want to cut my drain after the end of the surgery. I would like to measure the width and height of interlaminar window. I would like to correlate the spinolaminar junction and correlate that with the disc level. I also measure the distance between the spinolaminar line until the midline cleft of the ligament flavum. That is supposed to be described as half of the cranial lamina. I would also like to know where is the lateral V point, also the IAP SAP junction, and correlate them with the disc. Whether is it at the level of lower vertebral end plate, or is it above, or is it below? So in every level, it could be different. All these need to be taken into account before you start the surgery. This height definitely, which will be measured, and whether there will be up and down migrations. How far is it from the disc space? So we perform a lot of during the surgery. Whenever we encounter a yellow ligament, we can drill it aggressively without any worry, because we know that there are two layers of ligament. It's very difficult for us to punch through the ligament flavum. However, when we reach its end, for example, the pink part will probably resemble the dura underneath. Then in this case, we should be more meticulous and probably perform a slight circular movement, exert no pressure to prevent punching into the dura. So we can also respect the anatomy. We can go aggressive when we are at the level of medullary aspect of the bone, but when it comes to the inner cortex, then be a bit more careful. So it's important for us to define our limit. For example, the surgical corridor is limited by our upper limit, which is the the origin or the midline cleft of the ligament flavum. So preoperatively, I also measure how far is it from the spheno line? Is it one burr? Is it two burr, or even three burr? Then the caudal inferior limit is also defined as the insertion or the end of the ligamentum flavum. So sometimes we can't view the caudal lamina because of the superficial ligament. So I usually anticipate where's the location by my measurement before the surgery, and I use a burr to drill the caudal lamina so that the superficial ligament is being removed away from the caudal lamina. So we can also drill deep into the caudal lamina. And again, when we meet the yellow ligament, we can go aggressively. But however, when we reach the attachment, sometimes I use a blunt dissector to detach it from the bone, and then we can further kerrison it off. As for the lateral limit, most of them would advocate opening from medial pedicle wall. But however, during the surgery, it's probably not easy to see where is the mid ped the pedicle wall. So And during the surgery, it's not important to see the ipsilateral mid-pedicular line intraoperatively because it will be obscured by our hand and instrument. So it's also important for us to measure it before op and know where is it. So for me, I sometimes I measure from the IAP tip. Is it maybe 4 mm or 1 bird away? Then I also want to measure what's the distance from the sphenolamina line to the mid-pedicle line. And from here, I try to widen it using my drill. This is a left side approach, and then this is a right side approach. And this is the medial aspect of the IAP. This is a IAP and the SAP junction. With the meticulous calculation, I think that after this bone work and after removal of ligament flavum, invariably we will encounter the shoulder of the root. So I use a blunt dissector to mobilize it to visualize the D space, and this is the right side approach. So it's definitely important for us to interpret the imaging and correlate it to our endoscopic anatomical landmark. So I also like to perform a CT scan before I perform UB in every cases. So for example, in this case, we encounter a calcified disc. So we need to anticipate that in our surgery because sometimes we might confuse where is our location during the surgery because it might be difficult to be differentiated from the bone. Epidural hemostasis are important. So I think that this is a process during the uh, epidural space exposure, and sometimes we meet veins like this. So all these veins need to be coagulated using a RF device. And for example, and in this case, I use a 306 from Bonds. And once it invariably, I think all the cases we can reach the D space through the shoulder, and this is the retractor that protect the neurostructures, the thicker sac and the nerve roots over here. This is the left side approach, and I perform discectomy using a pituitary ronger or also a nerve hook. I I like to use the nerve hook to to tease to tease out this material. I think that this is a very non-traumatic method. So, and as for cases with down migration or also with central stenosis, sometimes we might have to go through the axilla, and typically the axilla, we will encounter the fat. So again, I will use a blunt instrument to tease out this material and then remove it with the pituitary ronger. So after adequate decompressions of the nerve roots, I also like to expose the PLL. And I also routinely use the RF device to to coagulate at the D space, at especially the annular defect, because I think that it helps to promote fibrosis and theoretically reduce the incidence of a recurrence. And most importantly, I think that it's give a good hemostasis and reduce the incidence of post-operative hematoma. So sometimes calcified these difficult case need to be anticipated before the surgery. For example, in this case, you can see that this is a hard disk, and I find it very difficult to insert my pen field into the disc space. So it's easy in UB surgery as we can use the Carrison to remove the calcified part of the annulus, and then later perform the discectomy, just like open surgery. So after the discectomy, to make sure that the nerve is adequately decompressed, first of all, I look at the structures of the nerve usually become more robust. also use a blunt instruments to try to mobilize the nerve to see how free is it. And then for a free nerve, sometimes when we push the water pressure, it is also mobile and freely moving. So the reason why I choose UB surgery is because we can use that to treat those patients with very severe symptoms, and we are not worried about the limitations of endoscopic techniques. So, and also it definitely it gives a good immediate outcome after the surgery, and it's painless with small incisions, and definitely it gives a wow effect to not the doctors, the patients, and definitely the family. So this is the patients whom I perform a cervical fluorotomy and accidentally caused a dura tear. However, these patients has no symptoms and just been treated conservatively. The UV technique is definitely cosmetically satisfying, I would say. And I would also perform trying to expand the indications of UB to treat cases like burst fractures with cord compression or also neurological deficit. So I would like to conclude that the UB is definitely an ideal solution for severe prolapse disc and also spinal stenosis because it maintains the minimal invasive of endoscopic surgery, yet it is as effective and powerful as open surgery. I think that a proper preoperative planning, water flow control, definitions of surgical opening limit, anticipation of surgical steps, meticulous hemostasis, adequate decompression will minimize the complications that's associated with the UB surgery. As surgeons refine their skill and knowledge, UB has the potential to revolutionize spinal surgery and enhance patient care. This is my reference, and I would like to express my gratitude to its three pioneers in neurosurgery, Dr. Song from South Korea, Dr. Dash from India, and definitely Dr. Yang He-jun from Zhengzhou, China, who is also the speakers for today's webinar. So thank you very much for the opportunity.